Okay. Now I've been getting a couple of questions with this. Very good questions. So I just want to go over it again so we can kind of clarify some of the process. Now, within that assessment, it is a little confusing at no fault to anyone or anything, but the way that this assessment rolls is you do your scene size up, your primary, and at the end of your primary, it's your determine your prioritize your patient, right? You try to prioritize your patient, but then you do an assessment, and then it's back to the rig. Remember, that head to toe stuff in real life, you're talking 30 seconds to a minute at best. So when I prioritize, yes, this is a priority patient, let's get the heck out of here. Partner, get the gurney, and the 30 seconds it takes to get the gurney. So in the 30 seconds it takes to go get the gurney, I'm going to do this 30-second assessment. Okay, so that's how we want to keep that in mind, right? So again, you'll get your dispatch. The dispatch is going to consist of respond for 25 male with a gunshot wound to the chest. It's very straightforward. Okay, it's very straightforward. It's not going to be secretive or mysterious, but it's up to you to translate that into that passing grade. Okay. With your dispatch, you'll get it, and then you'll have 10 minutes. Once you start the assessment, it'll basically start that 10-minute timer. Okay, so don't worry too much about the timing. It's not going to come down to the wire. Usually if it does, it's usually you're delaying several things. It's kind of a whole thing. Okay, so you start off, okay, standard precautions, scene safety. Proctor, is the scene safe? Yes, because there's a bunch of cops on scene. The patient is found, let's say he's found sitting upright. He's leaning against the wall of the bar, the building, restaurant, wherever they're at. He's sitting up and he's holding his chest. Okay, now you can see it. He's holding his chest, he's tracking me. Okay, so that's your whole scene there. Standard precautions, scene safety, we do have one patient. It appears to be obviously a mechanism of injury. With this patient, I definitely want to consider additional resources. I definitely want to consider the fire department, ALS, definitely want to consider law enforcement, but there's plenty of cops here. And because he's on the floor and gunshot wound, could be assault, we don't know what's really going on. Partner, go ahead and hold the head in a neutral inline position. The imaginary partner, hold the head in a neutral inline position. So we're going to just hold the head for right now. Now I'm going to move into my primary. Proctor, what is my general impression? What is my general impression? Just ask. Okay. Okay, your general impression, you have a 20s male. He is tracking you. He is holding his hand to his chest. Kind of consistent with that dispatch information, why you got called out. And pretty self-sufficient right there. He's on the floor, but he's watching you, meaning he's alive, he's awake. Okay, the fact that he's holding his chest, Proctor, as I walk up, immediately, Proctor, I want to take his shirt, put it over his head. Proctor, what do I see? Ask. What do I see? Okay, Proctor says, you see a hole in the right side of his chest. Proctor, I'm going to take my gloved hand. Immediately, I'm going to put my gloved hand over it. Remember, it's the gloved hand part because it's plastic. I want to cover the hole to prevent airflow. It's not direct pressure, it's airflow. So Proctor, I'm going to put my gloved hand over it. Imaginary partner, go ahead and give me a 3-sided occlusive dressing. Proctor, we're going to apply this on exhalation. Okay, go ahead and take a deep breath out, sir. Okay, we got the dressing on. At this time, Proctor, I want to go ahead and lift the patient up. Lift up the shirt. Proctor, I'm checking for any exit wounds. Do I see any exit wounds? No. Okay, put him back down. Still my general impression. Okay, right now, I want to check his AVPU. Right now, he's alert because you said that he was tracking me. And the rest of my GCS. Sir, my name is John. I'm an EMT. What's your name? What year is it? 26. What city are you in right now? San Diego. What happened to you? I got shot. Okay, so Proctor, and sir, kind of a silly thing, we can hold up 2 fingers. Okay, so right now, Proctor, my GCS is 4, 5, 6. Eyes is going to be a 4 because he was already tracking me, 5 because he knew all of his information, and 6 because he obeyed a symbol command. Okay, my chief complaint is penetrating trauma to the chest. My chief complaint is penetrating trauma to the chest. Some people list it as a gunshot wound. Okay, but remember, gunshot, that's the mechanism. Gunshot wound, The wound itself, that is the chief complaint. So slightly different, it kind of overlaps, sounds a little confusing, not too bad, okay? Chief complaint is penetrating trauma to the chest. Proctor, do I see any other life threats? Proctor, do I see any other life threats? No, not at this time. Okay, I'm gonna move into airway. Proctor, because my patient was speaking to me, this airway is open, it's patent, and he's able to speak to me, simple enough. Proctor, for breathing, what's the rate, what's the tidal volume, what's the O2 saturation? Rate is a little bit faster, tidal volume is a little bit deeper, O2 sat is 90%. Okay, so it's deeper, it's faster. Proctor, is it adequate? It's okay to ask that, is it adequate? Yes, it's adequate. Okay, based on that information, it's faster, it's a little bit deeper, but it's 90%. We're gonna put this patient on a non-rebreather face mask, and I'm gonna go to 15 liters per minute. Put that mask on. Does the patient accept the non-rebreather? Yes. Okay, so Proctor, with breathing, are there any other injuries that could be associated with breathing, such as any paradoxal movement, any other sucking chest wounds, or any type of flailed segment? I'm gonna assess for flailed segments by pushing down on the sternum, kind of like a karate chop. You're gonna push down once, hands over the chest, push down once, not on that wound that I already had, so I just kind of hover on that one. Push down once, and then push in once. Okay, for females, just above the breast, push down once, just below the breast, push down once, and in. One motion, I'm trying to fan my hands out to compress the entire rib cage in one motion. Okay, so any other injuries? No, besides what you've already addressed. Okay, so now I can go ahead and assess my circulation. Proctor, what's my pulse? I'm going to go ahead and grab a radial and a carotid on this pulse to check peripheral versus central pulses. You have a really extremely weak radial, and you have a very faint, a little bit stronger carotid. So there's a difference in peripheral pulses. Okay, so the rate, rhythm, quality of the pulse, rate is fast, rhythm is regular, and quality is going to be very weak and weak. Okay, so there's a difference. Skins. Proctor, take my gloved hand. What's the color, temperature, condition of those skins? Color is, let's say he's a little pale. Temperature is a little warm, or let's say it's cool. And condition, he's a little diaphoretic. Okay, partner, write that down. That's all I'm effectively I'm going to do with that. Okay. So at this time now, I want to go ahead and write that down. I want to do a blood sweep at this time. Remember, blood sweep is just blood. No injuries, no decap BTLS, it's just blood under circulation. So with blood, we're going to fan. Do I see blood? No. Take my hand, tuck underneath a little bit. Don't lift, just tuck. Do I see blood? No. Do I see blood? No. Do I see blood? Do I see blood? Oh, leg. Do I see blood? Do I see blood? Do I see blood? No. Tuck. Do I see blood? Do I see blood? Do I see blood? You have profuse bleeding or bright red, spurting bleeding coming from the left lower leg. Copy. Proctor, immediately I'm going to apply direct pressure. Is it bleeding controlled? Yes. Okay. Imaginary partner, put on a pressure dressing. Done. Okay. So now I'm going to come up to the arm. I'm going to go ahead and check the arm. I see blood. I see blood. I see blood. 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 I see blood. No. Okay. I can go ahead and check the capillary refill. Let's say it's immediate. Okay. Partner, write that down. I want to treat and manage for any shock with this patient, which they're showing some signs of shock. Partner, warm the ambulance to 85 degrees. We're going to go ahead and cover this patient up. You should have a blanket. Actually open up that blanket on the patient. Proctor, he's already on oxygen, and I definitely want to initiate rapid transport. Now for this patient, I want to keep in a semi-Fowler's position because of the chest wound, hemothorax, right, like we just talked about. I want to keep them semi-Fowler's. So you definitely want to keep it up a little bit, okay? Right now, I'll just put it down so you guys can see it, okay? So Proctor, I want to keep him up at a semi-Fowler's once we get him in the ambulance. Remember, he's on the floor right now, okay? He's on the floor for the scenario, but now, Proctor, I would want to put him in a semi-Fowler's position and definitely want a rapid transport to a trauma center, okay? For a sample history, I definitely want to get my ample, because remember, now I prioritize partner get the gurney. I'm going to do this 30-second, 1-minute assessment. So she's off getting the gurney. I'm going to do my sample. Okay, sir, do you have any allergies? Because remember, the S, that's my head to toe. That's my signs and symptoms. So just the ample. Sir, do you have any allergies to medications? Anything we have to be aware of? No. Are you prescribed any medications by a healthcare provider? No. Okay. Do you have any past or any diagnosis or any conditions diagnosed by a healthcare provider? No. What's the last thing you had to eat or drink? You had some chicken wings and a couple beers. Okay. Write that down. Events leading up. So I understand that you were shot. It sounds like it looks to be twice, but what happened? Got into an argument, push came to shove, pushed, and then you got shot. Okay. No real punches or anything? No. Just went to the gun. Okay. There we go. So I got my sample history. I'm going to do a head-to-toe assessment. Proctor, I'm going to check for decap BTLS, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. You say it the full time, the first time like that, everything else is decap BTLS. That's okay. So Proctor, I want to check the head. When I check the head, remember, I'm going to put my hands at the hairline and I'm going to push back. I'm going to push back. So Proctor, I want to check for decap BTLS. Do I feel anything? No. Actually put hands on the mannequin. Even though you're saying it correctly, even though your timing is great, everything is good and technically okay, if you don't put hands on the mannequin as I'm kind of doing it right now, that could be a critical fail. Okay, so just be careful. It's a two-way street with that. So fan out, negative. Take my thumbs, and basically I'm going to palpate the orbits and the forehead. Orbits, okay? Orbits, forehead, decap BTLS, nope. I'm going to check the nasal bone, good. Check the pupils. How are the pupils? They're reactive. Okay, partner, write that down. I want to check inside the nose. Check inside the nose, the mouth, clear. I want to go ahead and check the cheekbones, zygomas, or mandible, chin bone. We're good. Top, good. Proctor, I want to check behind the ears, for any battle signs. Proctor, do I see any fluid or blood coming from the ear itself? Nope, we're clear. I want to check the neck. For the anterior neck, Proctor, I want to check for any tracheal deviation. Palpate the trachea. Do I feel it? It's symmetrical. Okay. I'm going to go ahead and check for any subcutaneous emphysema. Do I feel that? Actually push. Negative. I want to check for jugular venous distension, JVD. In this patient, jugular veins are flat. That's a bad sign because in this patient, even though they're supine or semifallars, I should see it pop out. They're flat, which implies the pressure is low. Okay. So partner, write that down. Now I want to check the back of the neck, cervical spine, interlace, and walk down. Do I feel any step-offs, any crepitus, bone-on-bone crunching? I'm checking his face for any type of wincing or signs of pain. No. So now I check anterior, posterior. I want to check the chest. Proctor, any decap BTLS to the chest? No. I want to start with a jugular notch and then walk my fingers out, checking the clavicles. How are the clavicles? They're intact. Connect. Where I want to check the sternum, rib cage. All right, and push down once. With the rib cage, push down once, push in once. I'm going to auscultate second intercostal space, mid-clavicular line bilaterally. The fourth intercostal space, mid-axillary line bilaterally. What do I hear? Diminished on that right side and clear on the left. Partner, let's write that down. It's diminished. We already have that addressed. We're good there. Any other decap BTLS? No, we're good there. With the abdomen, I want to check Proctor for any type of distension, any bruising, discoloration. Do I see any of that? No. Any decap BTLS? No. The belly button, a vertical and a horizontal line. You have your 4 quadrants. You kind of want to make the hula hands. Heel goes down on the quadrant and rolls. So in one motion, I can feel the entire quadrant. Okay? When I palpate any rigid mass, pulsating masses, I feel that, 4 quadrants, nothing's found. Okay, so any hard, rigid masses, pulsating masses, we're good there. Genitalia, Proctor, we're gonna lower the shorts here. We'll check the genitalia for any bleeding, defecation, any urination. For males, any priapism, which is an erection that could be caused by lower spinal cord injury. Do I see any of that? No. Okay, I wanna check the pelvis. I wanna take the heels of my hand. I want to push down on the pelvis once and push in. So down once, in once, and done. Okay? Check the legs away from me in a direction they're not made to move. So high up in the groin, grab the upper leg, grab the knee, lower leg, ankle, and foot. Literally just kind of grab them and move them in a way they're not made to move. This side, high up, okay? Upper leg, knee, lower leg, ankle and foot. Any decap BTLS? No. All right, Proctor, I'm coming down to the feet. I want to check PMS, dorsalis pedis. Hands right on top. Pulses, are they equal? Present? Yep. Motor, sir, go ahead and wiggle your toes. Okay, go ahead and push down like a gas pedal. Go ahead and pull up towards your nose. Close your eyes. Which toe am I touching? 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 What am I doing now? Pinch. What am I doing now? Pinch. Notice how I did one at a time. Okay? So pulse motor sensory is intact in the feet. Come back up to the arms. Arms are last. Come back up. Upper arm, elbow. Lower arm, wrist and hand. Upper arm, elbow. Lower arm, grab, kind of a squeeze, move a little bit. Wrist and hand. Proctor, I want to check PMS. Pulses. Are they equal? Present? Yep. Motor, sir, go ahead and wiggle your fingers. Go ahead and squeeze my fingers. Okay, close your eyes. Which finger am I touching? Which finger am I touching? Which finger? Squeeze, what am I doing? Squeeze, what am I doing? All right, so Proctor, PMS is intact. The neck was negative. I got my sample history. At this time, imaginary partner, go ahead and let go. So after I assess PMS in those arms and legs, it appears that we don't have any C-spine issues, spine muscle restriction issues. Imaginary partner, go ahead and let go of the head. Now, Proctor, at this time, I want to go ahead and log roll this patient. Ready, 1, 2, 3. This hand is glued to the shoulder. Proctor, I want to go ahead and lift up the shirt. Do I see any decap BTLS? No. I'm going to go ahead and walk my hands like the keys to a piano, walking down, feeling the spine. Okay. I want to palpate the scapula. Any decap BTLS? No. I want to auscultate inferior angle of the scapula. Okay. What do I hear? Diminish on the right, clear on the left. Partner, write that down. I want to check the rest of the back butt, back of the legs, any urination, defecation, any bleeding? No. At this time, we're going to log roll the patient onto a backboard, mega mover, or scoop to get him up off the floor. Ready, 1, 2, 3, onto that device. Now, Proctor, we're going to lift him up, put him in the ambulance. Partner walks back 30 seconds later with that gurney. Lift him up, put him on the gurney. We're going to go. Proctor, in the back of a moving ambulance, I'm going to assess a set of baseline vital signs. Okay? I'm going to manage secondary injuries. We're going to reassess this patient every 5 minutes. Okay? Proctor may tell you, okay, at some point, your patient's respiratory rate, their O2 saturation, their pulse rate goes up, everything starts to just go out of whack, and basically your patient has